52-year-old alcoholic man develops left chest pain after repeated bouts of vomiting. On presentation, he is diaphoretic with fever of 101.5, heart rate 126, blood pressure 84/52. There are crackles and moderate dullness at the left base. The right lung is clear. He has subcutaneous emphysema over the left supraclavicular area. What is the likely type of pleural effusion? Hello everyone. Today we have an intriguing case involving a 52-year-old alcoholic man who develops left chest pain after repeated bouts of vomiting. Let's delve into the world of pleural effusion and uncover the likely type in this case. Our patient's presentation is concerning, with symptoms of diaphoresis, fever, crackles and moderate dullness at the base. He also has subcutaneous emphysema over the left supraclavicular area. But what could be the likely type of pleural effusion? Unilateral effusion refers to fluid accumulation on one side of the chest. While this option aligns with the patient's left-sided symptoms, let's analyze the contents of the effusions provided in the case to confirm the diagnosis. The left-sided effusion is described as turbid and has a cell count of 54,000 with 92% polymorph nuclear cells. Additionally, the pH of the effusion is 3.02, which is highly acidic. These findings suggest an inflammatory process and indicate an infection or another inflammatory condition in the left pleural space. Now, let's consider right-sided effusion. The right-sided effusion described in the case is straw-colored with a cell count of 150, which includes 20% mesothelial cells. The pH of the effusion is within the normal range at 7.42. These findings do not match the patient's left-sided symptoms and are not suggestive of infection or inflammation. Therefore, we can eliminate right-sided effusion as the likely type in this case. Lastly, we have bilateral effusions remaining. The characteristics of the bilateral effusions mentioned in the case do not match the findings observed in our patient. The turbidity, cell count, protein levels, and pH values of the bilateral effusions do not align with the clinical presentation and laboratory results in our case. Therefore, we can confidently eliminate bilateral effusions. By a process of elimination, the most likely type of pleural effusion in this case is a left-sided effusion. It's an exudative effusion caused by Boerhaave syndrome. Boerhaave syndrome occurs when the esophagus ruptures due to repetitive vomiting, allowing gastric contents to enter the left pleural space. This leads to an inflammatory exudative effusion. By categorizing the effusion correctly as exudative, we can differentiate it from transudative effusions and guide our management accordingly. In this case, the very low pH of the pleural fluid is a key indicator of gastric acid presence, distinguishing Boerhaave syndrome from other causes.